Okay, we'll go ahead and get started this morning. Thanks for making it to Grand Rounds today. I know it's a different venue, so thank you for kind of changing around your morning with us today. But today we have one of our second annual speaker series for the Dr. Raimondelli Lectureship, and I have a few prepared comments before we get going. But it's my pleasure to welcome everybody to the second annual Dr. Raimondelli Lecture and to welcome Dr. Raimondelli and his family back to Dayton. Just as a recap, Dr. Raimondelli was born and raised in Italy, and at the age of 10, his family immigrated to the United States near Pittsburgh. He was first in the household to attend college, to attend high school, never mind college, medical school, and a surgery residency program. After graduating from the University of Pittsburgh in 1970, he returned to his native Italy and pursued medical education at the University of Bologna, the world's oldest university in continuous operation, graduating as a physician in 1976. Dr. Raimondelli then returned to Pittsburgh to complete his internship and started his surgical residency at Shadyside Hospital. He transferred here to Wright State University School of Medicine in 1979 and finished the general surgery residency program in 1982. Upon completion of his training, he won a coveted fellowship in cardiovascular surgery at the Baylor College of Medicine in Houston, where he was mentored by the famed Dr. Michael DeBakey. Dr. Raimondelli returned to Dayton in mid-1983 to practice general and vascular surgery as part of Midwest Surgical's group at Good Samaritan Hospital. He rejoined the Wright State University School of Medicine faculty, helping to train medical students and surgery residents. As an aside, I knew Dr. Raimondelli when I was a resident, as general surgery resident here at Wright State. Dr. Raimondelli was one of the senior faculty members who was in the right side of the M&M room over at Good Sam, along with Dr. Seeger, and he was always the one to provide the sage advice during M&Ms, and he was always one that the residents wanted to work with in the operating room during residency training. In mid-1996, so hopefully it wasn't my chief class that drove you away, Dr. Raimondelli returned to State College in Pennsylvania to practice, and in 2014 became teaching faculty, a professor of the new Penn State Health Family Community Residency Program at Mount Nittany Medical Center. I would like to also thank and welcome and give a special thank you to Dr. Raimondelli's brother-in-law and sister, Dr. Arturo Porskansky and Nina Raimondelli Porskansky, who established this annual lectureship in Dr. Raimondelli's honor. This annual event will benefit present and future residents and faculty of our general surgery residency program, as well as the Boonshoft School of Medicine. This is a wonderful way to recognize Dr. Raimondelli for his lifetime achievements as an exceptionally compassionate, highly competent, and especially beloved surgeon in Ohio as well as Pennsylvania. More specifically, Dr. Raimondelli's family wished to express gratitude for the lifelong devotion for limb-sparing and life-saving medical counsel that he's provided. 3 generations of the family want to recognize in the gratitude and devotion that Dr. Raimondelli brought to his communities every day during his career. We appreciate your generosity in traveling from New York City and Pennsylvania to be here with us today. Thank you. So some of you might remember last year during the first annual Dr. Raimondelli Lectureship, Dr. Danielle Walsh came down from University of Kentucky, or came up from University of Kentucky. Dr. Walsh was a pediatric surgeon who talked about artificial intelligence, also did a workshop the evening before, and then did a session with the residents following the grand rounds that day. Dr. Shapiro, our guest lecturer today, did similar, had a wonderful workshop for some of the residents, and a few of the faculty were there last night, and on peer mentoring. And I would say after the discussion that we had last night, there's been discussion within the department. Dr. Galusha, Dr. Parikh, and myself, as well as the School of Medicine, about how we can establish a peer mentoring program, a more intentional peer mentoring program here at Wright State and even within the School of Medicine. So a year ago, when Dr. Walsh was here, we were beginning to plan for this event, and Dr. Tuttle, the program director, had heard and witnessed Dr. Shapiro's discussion at the 24th Annual Society of Breast Surgeons in Boston. And it was a plenary session that was dealing with adversity and uncomfortable situations. And I think Dr. Shapiro's discussion on how to handle a bad outcome was very impactful for Dr. Tuttle. And as we talked a little bit about it, it struck me at a time where, you know, we have these periods that we're working through events that may not have worked out the way we wanted to. And so we both agreed that this was our second speaker for the annual Raymond Deli Lectureship, and I'd like to thank Dr. Shapiro for making it to Dayton here with us today. But Dr. Shapiro is an associate professor of otolaryngology, head and neck surgery at the Harvard Medical School, principal faculty member to the Center for Medical Simulation in Boston, as well as a consultant for Massachusetts General Hospital Department of Anesthesia, Pain, and Critical Care. She was one of Brigham Women's Hospital first women division chiefs and has continuously worked for the advancement of women in medicine. She serves on the faculty of the Harvard Leadership Development for Physicians and Scientists and has been a faculty member of the Department of Surgery at Brigham Women's Hospital for over 35 years. Her surgical expertise was in treating adults with oropharyngeal dysphagia. In 2008, she founded the Brigham Women's Hospital Center for Professionalism and Peer Support, where she served as the director for over 10 years. During that time, the center became a model for national and international institutions, seeking methods to enhance a culture of trust, respect, and improve physician well-being. She continues to educate and assist organizations in developing specific programmatic educational approaches such as peer support, professionalism initiatives, and well-being programs. Dr. Shapiro received her BA from Cornell University and her MD from George Washington University Medical School. Her general surgery training was at UC San Diego and UCLA. She did her otolaryngology residency at Harvard, followed by a year of the National Institute of Health Training Grant Fellowship in swallowing physiology. She's married to an internist and they have 3 children. Please welcome Dr. Shapiro to the second annual visiting professor of the Dr. Salvador Raymond Deli Lectureship.
It's an absolute pleasure to be here, and I really want to honor Dr. Raymond Deli and the Porkansky family. I think it just takes such great vision to think you want to honor, you want to keep something good going. You know, how do you do that? And to actually execute that and make it happen. And I'm deeply grateful to be here for that, and also just the fact that you care about being very generative and thinking about the next generation. I think that's a beautiful thing. So thank you. I also want to thank Dr. Parikh for inviting me, and Dr. Woods and leadership of this department. I was saying this sort of offside this morning, is you don't get the kind of camaraderie that I already have experienced or heard about in this department without really relational and gifted leadership. So I think just remembering how important leadership is, and also thinking of yourselves, each one of you, as a leader, because you are. And you know, yes, as you go up the ranks, you may be leading more people, but even today, there are groups of people around you that depend on you and are looking towards you for how you act and you know, how you live your life. So just, it's a lot of responsibility, but it's also a wonderful responsibility. I have no technical disclosures. I put this comment about bias up here because we all have them, and I will always try to be aware of my biases, but there'll be times I might not be, and I want to mention that, my imperfection, and the fact that if I say something or I'm acting in a way that feels uncomfortable to you or what have you, that you would let me know about that. We need to kind of watch each other's backs in that sense. Before I start in specifically on peer support, I wanted to think about well-being in general, because you've all heard about well-being a lot. Fortunately, I mean, it's a good thing. You should know that people of my age, nobody talked about the well-being, our well-being. Nobody. It was literally not a factor. Complete carelessness in terms of how we were doing, which was really, I think, came from ignorance as to the fact that our well-being does matter. Fortunately, there were some really dedicated researchers who highlighted the problem of not attending to our well-being, and the reverse of that, in a sense, is burnout, and highlighted how much burnout there is. So there has been a lot of good energy in thinking, actually, our well-being does matter, and it's related to the outcomes that we care most about, which are high-quality patient care. Those two things, our well-being and high-quality patient care, cannot be separated. They're very intertwined. So there's fortunately, so many well-being efforts that you, I'm sure, have here and are, happening across the country and even across the world. And so I wanted to sort of make sense of, like, how do all these fit together, or what are these different kinds of efforts? So I think in the beginning, we had an overemphasis on individual resilience. Resilience, we talked about this last night, is a good thing. You can define it as growth through adversity. But the upshot of that was to go around doing well-being efforts, especially for trainees, saying, but all of us, you should be cooking your own healthy meals, training for a marathon. Don't forget to meditate a couple times a day and fit that yoga in. You might even want to do some volunteer work. These are all important resilience efforts. And they are. I'm not making fun of any of them other than training for a marathon, which I would never do. I think they are really important, and I'm not putting that aside. But what started to happen, understandably, was people started to think, why is the burden on my shoulders individually for well-being? Aren't there other factors that need to be addressed? And the answer is there are many factors that need to be addressed. And metaphorically, I would say it's unfair to have people deep breathe through what can be a very dysfunctional system sometimes, in certain ways, all of our hospital systems. So I think the recognition was, like, let's not just tell everybody what they should be doing to become resilient, but let's also think about other factors. So what are those? One, I think that gets sometimes overlooked, but there are certainly well-being efforts in this direction, is how wonderful it is to feel part of something, to be supported by colleagues, right? Teams and such. And so medicine, of course, has become very isolating to practice. Not because anybody said let's make it isolating, but it's just the nature of it, the busyness of it, the intensity, and we tend to, especially post-residency, we tend to not feel part of a community just because of the kind of the logistics of how we're practicing. So there are many well-being efforts that have focused on bringing us back into different communities where we feel supported and we can have discussions and such that we don't during the normal workday. So these are really important. And then last but not least would be organizational issues, essentially. What are our systems doing that are undermining our well-being? And this is not what I'm going to talk about today totally, but I do want to say this. I believe, and I'm not picking on any healthcare organization. I've had the privilege of working, with hundreds of healthcare organizations across this country and some internationally as well. And I can say that many of our healthcare systems are doing things that they should stop doing. And I will give you an example, and that is increasing the production pressure on individual clinicians, that you have to see more and more and more patients. And I got to tell you, at some point, that has to stop. It's terrible for those of us doing the work, but it's also not good for patient care. And so there are things that need to be looked at, like the EHR as well. How can this be something that is not burdening us, that's actually helping us do our work? And of all these, you have to, there's various organizations like the AMA is really working on things that are organizationally effective to actually decrease burnout. So that's really important. And the other thing I wanted to say about organizations is they, I think, are responsible for resourcing and promoting various well-being efforts, right? It shouldn't have to come from us individually or us as teams. So where does peer support fit into a well-being effort? It's not the cure-all, like I'm not saying this is it, because you can see, and I think that it's got what sustains our well-being is going to be multifactorial. So the efforts to improve well-being have to be multifactorial. Peer support is a specific initiative. And I made the Venn diagram, so I put it right in the center of where these intersect. It's meant to, on a one-on-one basis, to help individuals who you're supporting start to strategize and begin to heal. So in terms of that we know of well-being, to help them find their resilience. It's done by a colleague, so by definition, it's really relational. And it should be, in my view, resourced by the organization. And in addition, as you're doing peer support, issues that are organizational may come up, and those need to be anonymously, if you will, or confidentially shared with the organization so the organization can look at what's happening throughout the system that's undermining people's well-being and do something about it. So it's an individual effort. The other thing I want to say is that I am not here to tell you that you all are really behind and you need me here to tell you how to do this and that. No, of course not. You're doing great things. You have a wonderful system and leadership. I'm here to share something that I think is important and to see if you think it's important as well. We're all struggling with this in a good way, with this idea of how do we improve our well-being. So I was saying this last night, I consider myself an organizational change warrior. I love to think about organizations and think about what are we doing that's helping us be the best we can be, and we should do more of that, and where are we doing things that are really undermining our efforts, essentially. And so I'm going to be talking about the culture. When I talk about culture right now, I'm going to be talking about the culture of medicine writ large. I'm not talking about the culture at Harvard Medical School or at Mass General or Brigham. I'm not talking about your culture in particular. I'm talking about this common thread that I have found runs through everywhere I've been, and I'm very respectful of different regional and statewide and countrywide cultural differe's. There are many, and I love them. It's what makes travel so fun. But what I'm going to talk about are the similarity. There's some common threads in the culture of medicine across every organization I've had the pleasure of working with. And I want to just focus on one very positive one before I lead into one that I think is very problematic. And the positive one that always comes to mind when I think of the culture of medicine is that we're all healers. How great is that? Nobody is going to take that from us. That's why we're doing this work. But if we want to be better, I do believe we have to focus on some negative things. So I'm going to take you through some pretty negative stuff I think that our culture has promoted. And I promise, as I said last night, I'm not going to leave you in the nadir of despair because I believe there's ways to come out of this. So it's this, that our systems have treated us as inexhaustible resources, ignoring our physical, mental, and emotional health. As I said, we never thought about this. Literally, nobody talked about this back in the day. I'm just telling you, it wasn't on anyone's radar. What's problematic is it was never identified as an issue, and we have internalized these beliefs that we don't matter. We don't matter. And over the years, as I mentioned earlier, there have been some studies that have shown that we do matter, right? Which is funny that in healthcare, our own health didn't seem to matter. It's kind of ironic that we never gave ourselves the same care and each other the same care that we are dedicated to giving to patients. It's just ironic, but we've understood now that this view that we don't matter is really not sustainable. So I'm going to list some acute stressors that are part of healthcare, right? And some of them are part of healthcare regardless of how fantastic the system is. It's just due to the nature of our work. So I'm sure you could add to this list, but making an error, right? That's unfortunately inevitable because we're human and humans are wired to make errors. Adverse events where, an error is a subset of those where something happens, the outcome of the patient is related to our care in some way. Communicating with patients after adverse events. Just having emotionally stressful patient outcomes, nothing to do with our care, but bad things happen to people, and we are going to be seeing this. They're going to be coming to us for help, and sometimes there isn't anything we can do. Being complained about sort of officially by patients, it's pretty devastating. It feels terrible. We're not used to that. I mean, we're in this to make patients better. Negative feedback from learners. I mean, those of us who are educators know, how much we care about the people that we're helping learn, and how devastating it is to get significantly negative feedback about that. It can be really demoralizing. Patient aggression, which is unfortunately on the rise, and it can be just verbal or social media. And then, any kind of report to regulators, Department of Public Health, that kind of thing. So I can't, say an acute stressor without mentioning litigation. There's a high percentage chance in our careers that we'll be involved in this at some point or another, and it's, extremely stressful. Then you layer on top of that chronic stressors, or maybe underneath them, would be, healthcare disparities that we see, lack of autonomy in doing our work, corporatization of medicine, the overwork, as I say, that production pressure, having our work be undervalued in some ways, inadequate resources to do the work that we need to do. And then oftentimes within our own house, if you will, a house of medicine, bullying, harassment, discrimination, these are real things that are happening. And then you, of course, put something like COVID in there, and it really, the stress level is just huge, can be really quite huge. I do want to highlight that there are certain groups, and I'm just going to, in this slide, just talk about gender, that have some increased stressors just due to some, cultural biases, et cetera. And these are some of them that I put here, which may be experienced by women in particular, or non-binary people as well. And then I just want to mention what's called intersectionality, which that there are other groups that may intersect with gender or may not, such as race, where there's also other layers of stress that aren't experienced by other groups. And this is really something we need to keep thinking about, because we are working on handling stressors. So I believe that in order to sustain what the Institute for Healthcare Improvement calls our joy in work, we need to address the stressors. It's not that we don't need to, look at organizational things like how the EHR works, et cetera. We absolutely do. I do believe, though, if we don't look at especially some of the acute stressors, we're just going to miss the boat because they are so stressful, some of these. And I'm going to focus on one, where I think it's one of the most painful events that can happen in our careers, and it's where we've inadvertently caused patient harm. I am by no means suggesting that this is the only time we should be supporting each other, but it is a uniquely horrible moment in our careers, for sure. And so I'm going to focus on that. Understanding, I hope that you do, this is generalizable to peer supporting for any of the stressors. But if you can peer support for a colleague who's made a medical error, you can peer support for any stressor. So we know, some from personal experience, some from colleagues' experience, but also from very robust literature, some of the emotional fallout for having made an error. One is that we feel sad, right? It happened. It's just sad to see someone suffering. I think close on the heels to that, we may exhibit something called shame, or we may feel something called shame. And shame is where you go from saying, I feel really bad about that, to this happened because I'm not good enough. I'm not a good enough resident. I'm not a good enough PA, good enough physician, good enough nurse. It's something faulty within me. And it can really trigger self-doubt and the imposter syndrome. Now, there's no that I know of statistics on like how many people feel this, but I got to tell you, I have vast experience in providing peer support. I think it's probably close to 100%. There's some level of shame. And shame is very hard to bear. It really feels uniquely terrible. I was always wondering, like, why are we so ashamed after, after we've made an error? I just couldn't necessarily figure it out. And I thought the study that I'm going to show you is illuminating, where they looked at the similarity between aviation, the culture of aviation, and the culture of medicine with regard to errors. And they found that both stress the need for perfection and a deep sense of personal invulnerability. So what this means is that we are trained to believe that the way to keep, in our field, the way to keep patients free from harm is to expect error-free performance from ourselves and each other all the time. I would love if that were possible, but let me tell you something that you probably already know, that is physically impossible. You cannot eliminate human error from any enterprise because humans are wired to make errors. Does that mean we should give up on zero harm for patients? No, but it will never be from zero error. Just know that. It will never be, because that's an impossibility. So how would we keep patients free from errors? Well, one is individually, personal accountability. We make sure that we're well rested, that we're well taught, that we get help when we need it, those sorts of things, so that we can at least decrease the chance that we'll make an error, okay? In addition, we have to look at the system and say, is the system setting us up to make it more likely that we'll make an error? Like, for example, asking us to do two high priority things at the same time. So we're multitasking, that increases error rate just right there. And then, fixing those systems. And then in addition, the system needs to be set up to anticipate that there will be errors and make sure those errors don't reach the patient. That is a far cry from saying we're going to get to zero error rate, which is impossible. But I don't think that even though we know this, what I just said from patient safety science, I think it's something that we haven't internalized. This is a picture I took. I was at a stoplight, so no worries. But this was years ago, and I took a picture of a children's hospital van thing here, right? And look at their tagline, "Until every child is well." So I used to operate at children's for some of my work in otolaryngology, and this was what they were advertising. And I thought, this is the dumbest thing I have seen in a really long time. You're going around telling society that you're going to make sure that the reason that your hospital is going to make sure that every child is well, but that's impossible. That will never be the case. And so you're setting up societal expectations that nothing should ever go wrong or that we can cure anything, which is crazy. Now, I will say this, not because any input I had, but I didn't give any input. They don't use this tagline anymore. But it's just an example of what society has come to expect in medicine, an impossibility. I think fear, and I'm just going to ask anybody to volunteer if you can think of one thing that might strike fear in your heart after you've been involved in harming a patient. What are we afraid of? And I'm going to tell you, nothing you say is going to be unique. We are all afraid of certain things after errors. Anybody willing to just say one thing that we're afraid of, even if it's just theoretical? Thank you.
Ruining your relationship with the patient.
Absolutely.
How are they going to react to it?
Right, losing trust where we're used to being trusted. Is this going to undermine that, this incredibly important trusting relationship? What else are we afraid of? Thank you. A lawsuit, absolutely. Reasonable fear, not a raving paranoid thing. It's possible. Yes, what about our colleagues? Is that what you said? I want to make sure. Yeah, we care very much about what our colleagues think of us. And we're worried that this error will be viewed by our colleagues as like, they're not worthy, essentially. They don't trust us anymore, et cetera. Yes, thank you. Yes, I can't, this happened, but I don't think I could bear having it happen again. Absolutely, thank you. So I put some of these down. In some, some people have had job consequences, and I've worked in some countries. And most recently, I was in Japan, and it was at a patient safety conference. I spoke about peer support, but I understood from the people who invited me that in Japan they sometimes criminalize medical error, which is just unconscionable. So this is a really interesting study to me, okay? It's looked at what happens to the referrals to women surgeons when they've had a patient death versus referrals to male surgeons after patient death. And the findings were really interesting. Following a patient death, the referrals to women surgeons dropped by 54%. So that's some kind of judgment that a colleague has made about the expertise and trust they have in this surgeon, and that has gone down based on just a patient death without any specifics as to why. Didn't really affect referrals to male surgeons. So this, of course, is an example of gender bias. But why I put it in this presentation is because, to me, it's a specific example of a colleague judging us, right? So I mean, in this particular example, there's a gender bias to it, but we do judge each other, not just, but, gender-based, et cetera. And I will admit to, if I hear of a colleague making an error, maybe my first inner thought is, oh my God, what were they thinking? I have to become aware that I'm having that reaction internally so that that's not how I move forward. Then I stop myself and say, hold on, Joe, look, they are really smart and really dedicated. There's, let's find out more. There's probably a good reason for that. That's how you get rid of a bias, is you recognize it and then you don't act on it. But I put this up here to show you that this comment that you made, which is quite real, that we do worry about how our colleagues will think about us, it's a real concern. So this is, I just think, really an interesting viewpoint, which is that now, patient safety science is actually grounded in this understanding that we have to reflect on events that happened, bad outcomes, if we're going to learn. Not just to keep doing the same thing we were doing, but to learn from them individually and as a group. So let's talk about how that happens in organizations. Before I do, I'm going to ask a question. Did you all get an announcement that this hospital and the whole healthcare system and the med school were done with shame and blame? No. No place in the world sent out a memo. We're done with the very thing that's embedded in how we always react to bad outcomes. This shame and blame is absolutely the way that we have forever in medicine reacted to adverse events. Let's find out who did it and make sure they feel really bad so they don't do it again, and that will make the system safer. If it worked, I guess I'd be like a shame and blame, advocate, but it doesn't. It does the opposite. It undermines safety for many reasons. It undermines reporting. It undermines thinking about systems. It's completely not just inadequate, but it's undermining. But you cannot just go from decades of a culture that uses shame and blame as a reaction to adverse events, to a new system, which would be a just culture, safety culture, just by saying you're going to do it, right? You have to look at how have we embedded shame and blame so that we can stop embedding it and move towards this safety culture. So what is safety culture? It's basically a learning mindset. This bad thing happened. We're going to do as much as we can to make it right with the patient, and it is our moral obligation to look at the event, analyze it, and make sure that we change things, whether it's our own personal way of working or systems, so that it doesn't happen again. It's a learning mindset. It's not just blaming everything on the system, right? Because it's both personal accountability, what did I learn from this, and also systems accountability. So let's look at regulatory processes, which I will tell you, everywhere I've been, there are some that come into play after, especially after an error, but let's just use it generically as an adverse event. You might have a safety analysis. It could be an M&M, root cause analysis, patient safety committees. Sometimes the Department of Public Health is called in to look at the event, to analyze it. In Japan, they have the medical accident investigation system. I worked in the Netherlands for many years. They have the inspectorate that comes in. In the UK, it's the Royal College of Surgeons. It's physicians and surgeons. Every place has some kind of regulatory group that may be called in to, in response to an adverse event. And then we've got the media, which sometimes is weighing in, and sometimes the medical legal system. What I would posit to you is that every single one of these could be done in a just culture fashion, where there's a learning mindset, et cetera, if we decide we want to. Every single one of them. And you've probably experienced a root cause analysis or an M&M where it is a learning mindset. It is totally doable, but we have to decide mindfully we're going to do this and explicitly, right? Even the medical legal system. And I'm going to show you because it's real. They're called Communication and Resolution Programs, CRPs. They're across the country, very successful. They've been very well studied. They do all the right things in terms of outcomes. And the idea is, instead of the usual system that we use, we're going to be really transparent with patients and families regarding adverse events. We're going to look at what happened, why it happened, was it preventable, and how will we prevent recurrences, okay? In the rare case where we find there wasn't just an error, or maybe there wasn't an error, or there was an error, but it wasn't outside of the standard of care, those are mostly what we find. But in the rare cases where we find, you know what, this is outside of the standard of care, instead of having the patient have to sue us, we proactively offer financial and non-financial restitution. Okay, it's not the majority of the cases analyzed, but it is this group where these things happen, right? They do happen. This tends to keep the patients and families from having to get restitution by suing us. It involves no reporting to regulatory authorities, so they're blaming, there's no blame, right? It's like, okay, let's work together to move forward. And they're very successful. They're much less costly than the current medical legal system. Patients really, really appreciate them and the system, et cetera. So this is a learning mindset, right? That's kind of the basis of it, with transparency and compassion. So even our messed up medical legal system, which is shame and blame writ large, could change and has changed in many organizations. All of the emotions that I just delineated can lead to this sense of isolation, especially because around some acute stressors like errors, we have a culture of silence. We don't share this with each other. And isolation leads to acute and chronic stress. It is a very bad thing. What I would argue is that these are normal reactions, and it's the events that are abnormal. And that phrase, normal reaction to abnormal events, comes from the first responders, who were the people that we worked with to start thinking about training and peer support, because they have a very robust peer support system. I would not want to raise a generation of clinicians that said, after making an error, meh, not my fault, it's a system. Don't care, not feeling anything here. Of course we're going to hurt. We hurt because we care. And so it's not about eliminating these emotions. And many times these emotions actually just fade out over time. But sometimes they don't. And there is a ton of literature. I'm just going to put up a couple things to show you that can happen. We actually did a study looking at nurses and physicians when I was at the Brigham, compared to nurses and physicians at a hospital in the UK. No difference between the groups, and about almost a third experienced some significant negative consequences. We know that burnout and depression are independent predictors of having made a recent major medical error. And if you've made an error, you have a higher chance of becoming burnt out. If you're burnt out from any cause, you have a higher chance of making a medical error. We need to interrupt this cycle. And very sadly, the suicidal ideation rate for physicians is doubled after errors. And we know that it's a risk factor for physician suicide. It's not obviously the only factor, but it is absolutely a known risk factor. And it's just, we have to do something about this. We were looking at this I think we published this in 2012, but obviously before that to get the publication. What could we do to facilitate growth through adversity for different stressors. And we looked at lots of different stressors. This was a physician survey study. I'm going to show you the results of one question that we asked, which is if you were involved in a medical error, where would you want to get support from? And 88% wanted to be supported by a physician colleague, even though we had great employee assistance program and mental health providers. Another study looked at what is correlated with growth, resilience, and wisdom after errors, because not everybody experiences growth. Some people are literally crushed by this. And one of the factors was talking about it with colleagues. So we felt like we got to build a program around that. So we built an organizational peer support program and learned iteratively about how that would work best. The thing that we had to struggle most with was, okay, most places, if you ask, the leadership of most places, do you have any support for clinicians for different stressors? They'll say, absolutely, right? 100%, because almost 100% have some form of employee assistance program. The problem is those programs are typically not accessed by certain groups, especially physicians and APPs. They're just not. So you can have wonderful people doing wonderful things, but if the people who need the help aren't getting it, it doesn't do a thing for them, okay? And so that was a question that we wrestled with in an article we wrote for the New England Journal. What is in the way of getting help to people who might want it, and what are things that could facilitate getting that help? And they're not mysterious to any of you. This came from actually a study that we did around that I showed you before. Lack of, the question was, what would be a barrier to? Why wouldn't you ask for help? Stigma, lack of time, lack of confidentiality, and just kind of access issues. In the article, we talked about vulnerability being seen as weakness, where we really know vulnerability is courageous, right? But especially, I'm going to say, especially in surgery, vulnerability has been culturally seen as being weak, when it in fact is just the opposite. We have a culture of silence, which leads to isolation, as I said several times, and then we're sort of taught that self-care is selfish, that we don't deserve it. Right? We don't deserve it because our patients' needs come first, which they do. And I'm not talking about every day having like a 2-hour self-reflective moment or kumbaya. Come on, I mean, we're busy, okay? We don't have time for that. But never processing our emotions, never taking care of ourselves, not sustainable. It's just not sustainable. So ideally, I think that based on the data, peer support should be reach out and proactive, that we reach out and offer it. Don't wait till people are suffering greatly because they may be really silently suffering. I think if we could, even without a formal peer support program, start acknowledging emotions at times during the day, if you will, where it's relevant, like, bad outcome, just bring the team together, or the team is there saying, just let's pause for a second, this is rough. I know we have to go on the next case or the next whatever, but I just want to acknowledge, how hard this is, and that there's support for all of us if this is something that, that is desired. And having the leader say, this is tough, this is hurting, right? It's huge to acknowledge. And again, it's not every day we're talking about our deepest fears and such, but I'm talking about that we don't do this in the face of significant awfulness that we sometimes have to be part of. It's so countercultural. I think we should offer peer support for lots of different things, litigation. I'm just going to skip that unless anybody has a question. But all these things that we talked about, you're head of some department of education, and you know that a faculty got some significant negative feedback, is reaching out and helping them get perspective that this was just this one person who felt this way, et cetera. We should also be able to connect people with further resources, because formal peer support is just a one-off still. It's deeper than informal, but and people may need longitudinal support. So I believe and hope that peer support, in addition to helping individuals, is also a cultural change driver, right? It goes from shame and blame, pushes towards just culture. This idea that we're supposed to be perfect and error-free, it helps push towards, hey, this happened because you're human, not because you're unworthy and bad and dysfunctional and incompetent. Sorry, this just popped into my head, but back when I trained, there was this phrase that would sometimes be said to trainees, and I actually didn't have particularly malignant training, but let me just say, so let's just say it wasn't in my hospital, but this absolutely was said to trainees when something went wrong: are you stupid or do you just not care? Nice, right? Somebody told me that they heard this recently. So, we're not out of the woods yet. We're getting better. But this idea, that you are supposed to be perfect and you made an error, so you're not worthy, that's just got to go away. The expectation that something went wrong, but it shouldn't hurt you, march forward, put your head down, get your work done. Hey, you're human. Of course it hurts. And I hope, it pulls us into this idea that you're not alone. This has happened to all of us. We all have different ways of feeling it, but they're not completely unique. And that, self-care is not selfish, it's essential. So I don't use the term second victim. I don't know if anybody noticed that. I don't use it because the patient advocates that I have worked with over the years really don't like our referring to ourselves as victims after we have harmed them. They don't like it, so to me that is a reason not to use the term anymore. I know the person who started the term, and I love him. He's amazing, Albert Wu, and I think it was so helpful because it shone a light on this phenomenon, but it needs to be retired. And so this is a quote from one of the a paper by patient advocates. And underneath there's an article that we wrote, pro and con, a group of us saying it should stay, a group of us saying, I don't think so. Okay, so I want to summarize the key points: that many stressors we face are inevitable, even with the best of systems. We suffer because we care. Peers have a unique opportunity to help us navigate these stressors. That's the most important one. There's something so special about being supported by someone who gets it on the deepest possible level. There are multiple barriers to getting that help, and so support programs have to be organized and structured to overcome these barriers so we can actually get help to the people who need it, never forcing it on anybody, but making it very easy to access. I'm going to end with and we have time for questions. I'm going to end with a quote that has nothing to do with peer support, but to me it has everything to do with it, that was on X. It was Twitter at the time. I dream of never being called resilient again in my life. I'm exhausted by strength. I want support. I want softness. I want ease. I want to be amongst kin, not patted on the back for how well I take a hit or for how many. Instead of hearing you are one of the most resilient people I know, I want to hear you are so loved, you are so cared for, you are genuinely covered. And I would like us all to feel that way. And I think it's true here. I think you are loved and covered. It's just a matter of kind of accessing that feeling and knowledge in the moment of real stress. So thank you so much for inviting me. I welcome, a lot of times after presentation, we say, okay, any questions, but I want to open up to, you don't have to have a question. You can just say, this is how I feel about what you said, including like, I don't buy it, or yeah, this part is great, or I wonder about this. So please, 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 very, very interested in your thoughts. And I also want to thank you, as I said last night, for being here, but also for the work that you do. It's so special and wonderful and invaluable. Thank you. Anybody, how does this land for you? What do you think? Yes, thank you.
Within the physician community necessarily, but it's that the system
that what you say is absolutely true. So just to repeat it, basically the idea that peer support is helping us deal with the problems, right, distressors, but it isn't actually going to make any structural systemic changes if they are the underlying cause for it. So in some ways, it's why I use errors as an example, because even with the best system, errors are errors, right? But that doesn't mean that in the M&M and the root cause analysis, that's where we should be looking at what are the other factors in addition to my learning, what about things that need to change. So that should be happening in parallel. The peer support is for how are we going to strategize going forward, but exactly what you said, so even if we use errors as an example, exactly what you said should also be happening. One of the things that I've experienced in peer support is where a systems issue comes up as problematic. So when I do training for people to be peer supporters, what I explain is like, you can react to that. So I've had somebody say, and some of this is for new simulation of a peer support during a training, M&M is unsafe. People are going to be, they're talking about me behind my back and they're going to make me humiliated. Let's say I'm doing the peer support, but I have no control over M&M. What I would say to that person is, that's horrible and wrong and unsafe in and of itself. I want you to know that that's just terrible that you have to deal with that. So to acknowledge the systems issues, if you will. But the peer support isn't there to put the burden on the individual or on the peer supporter to actually make changes, right? It is really to manage how they will navigate it, but acknowledge that really what should happen in addition to their healing is the system should change. So even in sometimes peer support, I might say, is there someone you can talk to about this? Like, is there a way do you trust anybody to, talk to about this and ask if maybe M&M could be made safer? I mean, I know you're talking about much more big systems. Those systems issues absolutely have to be addressed. So I look at this as a yes and, okay? I think it's gotta be both. Peer support is really on that personal level. That said, if the peer supporters are organized, which in many organizations we have, I've helped them develop organized programs, and there are thematic things that happen that the organization should be aware of, absolutely, they should be made aware without using the name of the people they peer supported. So thank you for bringing that up. You're absolutely right. It doesn't solve everything by a long shot, but I think it's a good step. Just put it out there. This is messed up. Thank you. Yes.
Thank you, Dr. Shapiro, so much. I run the M&M.
He said thank you. He liked it.
I run the M&M, so everybody's going to look at me like, oh.
Yeah. Okay, now, how's it going?
Better. I'm okay with that. So the question I have is, I think that this definitely explains why it's important. In your experience in the hospitals you worked at, what specific programs have you implemented to assist with peer support? For example, does everybody get an interview program director? I mean, we do that already, but for just peer support, or do, like, for example, after M&M, do I sit down and give peer support to people who just, what things practically have you implemented to help?
Okay, great. I'm going to repeat this for the Zoomers. So the question is, what have I seen, or what do I recommend in terms of how to, I would say, integrate this into something like, for example, M&M, or just in residency training, should we have interviews, just proactively giving peer support to each of our trainees, those sorts of things. That particular thing, probably not. I think, in terms of saying, like, let's sit down and do peer support for each person. The way this is structured is more of an event-based or a stress-based one. There's something in particular that is stressing somebody. Not that you couldn't be supportive. I mean, the peer support tools are basically good for just regular, relational work. But the M&M, I want to add to, I do think it should be structured. Not that you provide peer support during M&M, because I have to tell you, I mean, I was a division chief, and I used to actually run M&Ms for years. it's just not feasible and it's private. People aren't going to be in the middle of, all their attendings, residents are going to be like, I feel worthless, I don't know if I'm competent. I mean, that's just not going to happen, right? So it's got to be done, I think, one-on-one. That's why we generated the one-on-one. You can do peer support for a group, by the way, after a stressor. So what I would say with M&M is, first of all, here's how so we actually did a study on looking at different ways, M&Ms and all RCAs are handled. One of the things that we concluded was, this is an idea of a framework for M&M, is starting the M&M by saying, we're not here to find out, to blame anybody, but we're here to look at the following. Knowing what we know now about this event, what would we do similarly going forward? What did we do well, and what should we not do? How should we make changes? We're here to learn from each other. So you sort of set the tone of like, this is explicitly what we're gonna do. Because I think sometimes it's not everybody's mindset. And then if it's something that was very stressful, and you run this and you can say, I want to acknowledge that these things are really tough. In our careers, and I want you to know that I'm available for, or we have a program for, or there is support, and please let me know. Have a very low threshold for just saying, I'd like to talk more about this. So, and especially coming from you as a leader, not just that. Oh my gosh, like maybe we have emotions around this, but like so that you invite, just acknowledge. These things can be tough. Yes?
I'd just like to say that Dr. Rudd does, every time on Monday when we have our M&M here at the Valley, that he does present those things. And he does say, hey, this is just a learning experience. We're all here to do the great things. He checks in with everybody before we even start the presentation. So I think Dr. Rudd did it.
Okay, so the comment was, everything I just said was already done. Nothing like somebody who tells you to do something that you're already doing. So we had to have her come in from Boston to say that? Yeah, I don't think so. Right? No, I'm just completely making fun of myself. That is completely what I'm doing. No, that is wonderful. And so I think maybe the extra step would be, and by the way, and I know, most people running M&Ms don't do that, but maybe the extra step you might want to add is, look, this can really land hard. It has for me at times, whatever, and there's more support available, which we can do privately, something like that. Yes.
Thank you, Dr. Shapiro, for coming. You brought up very, very good points. Some of the young learners and historians probably not my friends. I see how things work.
Yep.
One of the stressors you talked about is project transmission. And not so long ago, patients started being referred to as customers, which should be totally condemned and should never accept it. So what it does is to undermine the cooperative relationship between the patient and this foundation. The reason why I chose to go to medical school is for that caring, show empathy, loving, etc., which is totally different from a customer. So there's been a culture of corporate invasion of medical care, and and it can be very stressful in a because they have the customer service in a hospital, and they want to make you believe that you are, an Orman dealing with the customer. It totally undermines that corporate relationship and should absolutely reject it.
I totally agree. I think, I did list it as a significant stressor. So the comment was totally well formulated, and that is that stressor is that corporatization of medicine. And an example given was, referring to patients as customers. So what I want to say, and I'm a little bit of this sort of off script, but of the view of, this system is messed up. Let's blow it up and build something beautiful. And when I say blow it up, I mean let's acknowledge and see how this is affecting us and in what ways it's being put forward, like language, and saying I'm not going to ever call my patients customers, and telling leaders stop using that term, right? Because words matter. So looking at the individual things that they're ruining, I would say, our relationship with our patients, because seeing patients as customers it's just like I said with anything. You have to notice what's going on. What is the culture? And that is the culture that's has been really pushed forward. We can resist in many ways. And I'm all for, civil disobedience, whatever that may look like, is to say, this is not okay. And if corporatization of medicine means they've loaded too many patients onto each of us, to say, absolutely not. We're not going to do that, right? I mean, I know it's not as simple, but, we're powerful in our way, but we need to make our voices heard about things that we think are important. So thank you for bringing that up. I think it's so subtle sometimes, right? Just even the word usage. But let's notice it like you have, and then talk about it, and then talk to the people who are using the terms or making us do things that really are corporate and not in the best interest of the patients. Thank you. Yes, and I think that we should take this as the last one, right, time-wise? Yeah, okay, yes, thank you.
Thank you so much, Dr. Shapiro. It was a really important presentation, and I know that for my fellow students, this is something that we carry on. Have you seen whether or not there's been an actual shift in changes within the healthcare system providing support for physicians since COVID that have continued to be effective?
So the question, thank you are you a medical student? First of all, thank you for raising your hand and speaking. So important. So I hope, I'm going to credit myself that I created a safe space, but I don't actually. It's a real credit to you. So that's awesome. And the question was, have I seen, since COVID, successful efforts to actually, and did you use the word well-being, to focus on that, in medicine? And the answer is yes, I absolutely have. I'll tell you a very specific, well, for one thing, from my point of view, obviously I have a certain lens, is I get engaged when people call me and say, we want to develop a peer support program at this hospital or this healthcare organization. And the requests for that have just shot way up during COVID. Even though people were feeling overwhelmed, they were like, oh my gosh, this is terrible. What's happening here? We've got to do something. So there was that. But it's completely outside of myself. So Lorna Breen was an emergency medicine physician. A friend of ours' son was a resident when she was she had hers in attending, and said she was amazing. And she got COVID, and then tried to come back to work too early. Anyway, she died by suicide. And it was in the national news. And she was supposedly just an incredible physician and colleague and human and educator and all those good things. So her brother-in-law started the Lorna Breen Foundation, and they actually got into Congress kind of a stipulation that funds have to be given for not just suicide prevention, but well-being efforts for physicians. I don't know if it said just for physicians or healthcare providers, but it is in there. So what I want to say is there's been a heightened awareness of the urgency of doing this. And so more places, I think, are actually saying, what can we do to prevent suicide, for example, or to improve well-being? And on a very specific level also around that is they've been lobbying, which we had been doing we being the people in the well-being community for a while, but they push it forward even more, lobbying the Federation of State Medical Boards to stop asking us on our licensure if we've ever had mental health issues that we've received help for, because it has stopped physicians from getting help. They don't want to put it on their licensure. And by the way, it's none of their business. Unless whatever condition you have is interfering with your ability to practice medicine, and that needs to be declared, that's very different from I had issues and I got help. None of their business, and there's still some states that ask that and some hospitals that ask that in credentialing. So very structural changes around how are we impeding or facilitating getting support for our mental health as physicians. Again, thank you, and thanks for the work that you do, and thanks for being here.